Welcome to the MRCS Bites session on Head and Neck Anatomy and Pathology, OSCE Station 1. Today, we'll dive into this topic and explore the common questions tested during the MRCS Part B exam. For more information and full course, please visit mrcsbites.com. Question 1. Name the layers of the scalp. The layers of the scalp can be remembered with the mnemonic scalp. Skin. This is the outermost layer, containing hair follicles, sweat glands, and sebaceous glands. Connective tissue. A dense layer of connective tissue that contains nerves and blood vessels. Aponeurosis, Galea aponeurotica. A tough layer of dense fibrous tissue which acts as a tendon for the occipitofrontalis muscle. Loose areolar connective tissue. This layer allows the outer layers to move freely over the underlying structures. It contains a potential space that can fill with fluid from injury or infection. Periosteum. The innermost layer, which is the dense layer of vascular connective tissue enveloping the bones of the skull. Question 2. In which layer of the scalp is the neurovascular bundle located? The neurovascular bundle of the scalp is located in the connective tissue layer, which is the second layer of the scalp. This layer is dense and fibrous, containing the arteries, veins, and nerves that supply the scalp. Question 3. Through which layer of the scalp do soft tissue infections spread and why? Soft tissue infections of the scalp tend to spread through the loose areolar connective tissue layer. This is because this layer contains a potential space that allows for the easy spread of infections. Question 4. What is the arterial supply to the scalp? The arterial supply to the scalp comes from branches of both the internal and external carotid arteries. Internal carotid artery branches. Supratrochlear artery. Supplies the forehead and anterior scalp. Supraorbital artery. Also supplies the forehead and anterior scalp. External carotid artery branches. Superficial temporal artery. Supplies the temporal region of the scalp. Posterior auricular artery. Supplies the area behind the ear. Occipital artery. Supplies the posterior aspect of the scalp. Question 5. Which nerves supply the scalp? The scalp is innervated by branches of both the cranial and cervical nerves. Cranial nerves branches. Supratrochlear nerve. A branch of the ophthalmic division of the trigeminal nerve, CNV1, that supplies the forehead and anterior scalp. Supraorbital nerve. Another branch of the ophthalmic division of the trigeminal nerve, CNV1, that supplies the forehead and anterior scalp. Zygomaticotemporal nerve. A branch of the maxillary division of the trigeminal nerve, CNV2, that supplies the temporal region. Auriculotemporal nerve. A branch of the mandibular division of the trigeminal nerve, CNV3, that supplies the area in front of the ear and the temporal region. Cervical nerves branches. Lesser occipital nerve. A branch of the cervical plexus, C2 and C3, that supplies the area behind the ear. Greater occipital nerve. A branch of the dorsal ramus of the second cervical nerve, C2, that supplies the posterior scalp. Question 6. What are the signs and symptoms of giant cell arteritis? Giant cell arteritis, GCA, also known as temporal arteritis, is an inflammatory disease of the blood vessels. The signs and symptoms can vary but commonly include headache, severe, often localized to the temples but can be diffuse, scalp tenderness, especially when combing hair or touching the scalp, jaw claudication, pain in the jaw muscles while chewing or talking, visual disturbances, blurred vision, double vision, or sudden, permanent loss of vision. Fever, low-grade fever, often accompanied by other systemic symptoms. Fatigue and malaise. Weight loss, which is unintentional. Polymyalgia, rheumatica, pain and stiffness in the shoulders, neck, and hips. Question 7. What eye conditions are associated with GCA, and what's the commonest type? Giant cell arteritis can lead to several eye conditions due to inflammation and occlusion of the blood vessels supplying the optic nerve and other ocular structures. The eye conditions associated with GCA include anterior ischemic optic neuropathy. This is the most common type of vision loss associated with GCA. It occurs when the blood supply to the optic nerve head is compromised, leading to sudden painless vision loss. Central retinal artery occlusion. This condition occurs when the central retinal artery becomes blocked, leading to sudden and severe vision loss. Posterior ischemic optic neuropathy. This involves ischemia of the optic nerve behind the eye, causing vision loss. Choroidal ischemia. This condition involves reduced blood flow to the choroid, the vascular layer of the eye, which can lead to vision problems. Ocular motor nerve palsies. Inflammation of the blood vessels supplying the cranial nerves responsible for eye movement can lead to double vision or other eye movement disorders. Among these, anterior ischemic optic neuropathy, AION, is the most common eye condition associated with GCA. Question 8. What are the key investigations to consider for a patient with suspected GCA? Erythrocyte sedimentation rate. Elevated ESR is a common finding in GCA. Temporal artery ultrasound can show characteristic findings such as a halo sign, indicating inflammation of the temporal artery. Temporal artery biopsy, considered the gold standard for diagnosing GCA. A small section of the temporal artery is removed and examined under a microscope for signs of inflammation and giant cells. Question 10. What would be the histological features of an arterial biopsy of a GCA? The histological features of an arterial biopsy in a patient with giant cell arteritis, GCA, typically include granulomatous inflammation, presence of granulomas, which are collections of macrophages, often surrounded by lymphocytes. Giant cells. Multinucleated giant cells, which are formed by the fusion of macrophages, are often found within the granulomas, particularly at the internal elastic lamina. Disruption of the internal elastic lamina. Fragmentation or disruption of the internal elastic lamina is a hallmark of GCA. Intimal thickening. Proliferation of the intima, the innermost layer of the artery, leading to narrowing of the arterial lumen. Lymphocytic infiltration. Dense infiltration of lymphocytes in the vessel wall. Mural inflammation. Inflammation involving all layers of the arterial wall. Intima, media, and adventitia. Question 11. What are the main treatment options for GCA? High-dose prednisone is the first-line treatment. Patients are usually started on a high dose, 40-60 mg per day, to quickly control inflammation and prevent complications such as vision loss. Intravenous methylprednisolone may be used in cases of acute vision loss or severe symptoms prior to oral prednisolone. The dose of prednisone is gradually reduced over months to years, depending on the patient's response and recurrence of symptoms. Regular follow-up with a healthcare provider to monitor for side effects of treatment, disease activity, and potential complications is important. Immunosuppressive agents such as tocilizumab, methotrexate, azathioprine may also be considered. Aspirin is often prescribed to reduce thrombotic complications. Prompt and adequate treatment is essential to prevent serious complications of GCA, particularly vision loss, which can be irreversible. Question 12. What are the signs and symptoms of trigeminal neuralgia? Trigeminal neuralgia is a chronic pain condition affecting the trigeminal nerve, which carries sensation from the face to the brain. The signs and symptoms of trigeminal neuralgia include sudden, severe, shock-like, or stabbing pain that usually affects one side of the face. Pain episodes can last from a few seconds to a couple of minutes. The pain can occur in rapid succession or in a series of attacks over a span of hours or days. Pain can be triggered by routine activities such as chewing, speaking, brushing teeth, touching the face, or even a light breeze. Specific areas of the face, known as trigger zones, can precipitate pain when stimulated. Pain typically affects one or more branches of the trigeminal nerve, often involving the lower face and jaw, mandibular branch, or the area around the nose and upper lip, maxillary branch. Less commonly, it can affect the area around the eyes and forehead, ophthalmic branch. periods of no pain, remission, that can last days, weeks, months, or even longer. Over time, the frequency and intensity of pain episodes may increase, and periods of remission may become shorter. The severe pain can lead to anxiety, depression, and a reduced quality of life due to the unpredictability and intensity of the pain episodes. Unlike other neuropathic conditions, trigeminal neuralgia typically does not cause numbness or weakness in the face. Question 13. What drugs can be used to treat trigeminal neuralgia? The treatment of trigeminal neuralgia primarily involves medications that help to manage and alleviate the pain. The main drugs used include anticonvulsants, such as carbamazepine. This is the first-line treatment for trigeminal neuralgia. It helps to reduce or block the pain signals sent to the brain. Gabapentin. Often used as an adjunct to other medications, it can help to control pain. Lamotrigine. May be used in patients who do not respond well to other anticonvulsants. Phenytoin. Sometimes used as an alternative, especially in acute situations. Muscle relaxants, such as baclofen. This can be effective either alone or in combination with anticonvulsants. Tricyclic antidepressants, such as amitriptyline. Question 14. What are the surgical options for trigeminal neuralgia? Surgical options for trigeminal neuralgia are considered when medications are ineffective or cause intolerable side effects. The main surgical procedures include microvascular decompression, MVD. This involves a craniotomy to expose the trigeminal nerve and reposition or remove blood vessels compressing the nerve. Gamma knife radiosurgery. This is a non-invasive procedure using focused radiation to damage the trigeminal nerve root and reduce pain signals. Radiofrequency rhizotomy. This uses heat generated by radiofrequency energy to selectively damage the trigeminal nerve fibers, reducing pain transmission. Balloon compression. A balloon is inflated near the trigeminal nerve root to compress it and damage the pain fibers. Glycerol injection. Injection of glycerol into the trigeminal nerve root to chemically damage the nerve and reduce pain transmission.